So it's going to be a debate on inositols for PCOS, whether it is a hope or hype for these patients. So first on, we welcome Dr. Swaramya, who is a gynecologist. Whose specific focus is on research in PCOS and metabolic syndrome. She is from Pondicherry, and she has many academic accomplishments to her credit. She is a gold medalist in her undergraduate days, and also she has an award of excellence in her MBBS period. And she also has publications in metabolic syndrome in women with polycystic ovary syndrome. So over to you, Dr. Swaramya, ma'am.
Yeah, thank you so much for the introduction. Can I start my screen sharing? Could you please enable it?
Yeah.
You can share now.
Yeah, so you can see my screen now?
Yes, ma'am.
Yeah. So, yes, so this whole talk is about inositols and polycystic ovarian syndrome, and I'm here to say, yes, there is a lot of hope for it. So, good morning, all of you. You know, when I was initially offered this debate topic, I was like, wow, so you really want me to say, yes, there is hope for inositols and PCOS? I'm like, okay, yeah, I've probably got an easy topic to discuss about. So why is there so much discussion about what to do for PCOS? Because the search goes on and on for the wonder drug. We're still looking for the magic bullet in PCOS. But why PCOS? I think probably all of us know, right? The implications of PCOS is just beyond irregular periods now, the long-term consequences of metabolic syndrome, obesity, cardiovascular outcomes in terms of malignancies, breast cancer and endometrial cancer, the psychological implications. I think the impact of PCOS now is understood to be beyond just reproductive and gynecological outcomes. Our conventional approach has been to say, okay, so you're coming to me with PCOS now. What do you want to do? Oh, yes, please, first figure out your diet. Figure out a proper exercise regimen. Lifestyle modification is of paramount importance. That's where you need to go to first. Well, let's get honest here, okay? However much I would like to say lifestyle modification is probably the most crucial intervention in PCOS. It's not always possible, and probably as an isolated intervention, it may not be enough, okay? Okay, metformin is there. It works well. It helps in the insulin sensitizing phase. It helps in regularizing periods. It improves ovulation. It's an extensively studied drug. There's a lot of cardiovascular outcomes that are favorable in favor of metformin. Why do you want inositols? Is there something beyond metformin? Is there something better than metformin? The whole point is that how much compliance can you really expect from metformin, considering that there is quite a significant adverse effect profile in terms of what it does to your GI system and patient acceptance. Is it something that you need to administer long term? So probably it has not ticked all our boxes in what could be an ideal intervention in PCOS. So that's why we are looking for something beyond and better than what we already have. So primarily, when we're talking about inositols, we need to know whether it actually addresses what the pathogenesis of PCOS is presumed to be. And the second half is about, okay, it's not only about the pathogenesis. Now you've told me, okay, the pathogenesis is relevant. But you really see when inositols are used as an outcome, is there a measurable clinical outcome when you use inositols? So let's just answer this one by one. A very, very familiar concept to all of us, especially metabolically, about insulin resistance and how inositols are involved in the intracellular signaling pathways. And this intracellular signaling pathways not only holds good in the general physiological system in the body, but specifically in the ovary also, right? So now, is inositol, we know now that the pathogenesis of PCOS has probably, we're coming to a consensus that it is all about insulin resistance, both in the peripheral system as well as in the ovaries. Now, is inositol dysregulation really involved in nurturing PCOS and causing the progressive metabolic consequences secondary to PCOS? I'm not talking about inositol supplementation, but the role of inositols in PCOS, endogenous inositols in PCOS. There is in vitro evidence that there is intracellular increased epimerase activity, and the concentrations of myoinositol and decaroinositol in follicular fluid, in the ovarian follicle or follicular fluid. These measurements tell us that there is an endogenous inositol involvement in the etiopathogenesis of PCOS. So I think we can confidently say that an ovary of a PCOS woman suffers from a specific myoinositol depletion and chiroinositol overload. So yes, now insulin resistance is a primary key pathogenesis, and there is an endogenous inositol disturbance in PCOS. So now, can exogenous inositols, now that we have determined that there is an endogenous inositol metabolic disturbance, can an exogenous inositol, therefore, as a conclusion, be considered for a further approach to PCOS? So what are we trying to answer? Are there biochemical in vivo outcomes? So after exogenous inositols are administered to a woman with PCOS, do I have definitive evidence saying that there are in vivo outcomes which I can measure and tell you, yes, my inositols are working, in terms of, is fasting insulin level increased? What about the HOMA index? What happens to the androgen levels? What happens to the sex hormone binding globulin levels? Is there evidence to say that this works? Yes. The 2013 international consensus on the use of inositols in obstetrics and gynecology tells us, yes, there is evidence that tells us that this really works. But hey, wait, there's a catch here. The consensus said that there's only one trial available, and this study was carried out in postmenopausal women. Now, can I extrapolate this to young women in their reproductive phase, in early menarche? Because we're looking at something like primary prevention, right? So why am I saying that this is a valid point in my debate and actually believe that this study in postmenopausal women can be extrapolated to the younger population? I just contradicted myself, but I don't always contradict myself. But when I do, I still don't. So I'll tell you what the fallacy here is. The international consensus came out in the year 2013. So the studies that were reviewed were two studies which were carried out in 2011 and 2012. Now, it's more important to look forward and look what the recent evidence says. A meta-analysis came out in the year 2017, which analyzed subsequent randomized control trials, about 9 randomized control trials, which included nearly 500 women. So the primary outcomes of the study was about fasting insulin concentrations. Yes, there was a decrease in fasting insulin concentration noted. And secondary outcomes like HOMA index, the testosterone levels, and sex hormone binding globulin plasma levels, everything had a favorable impact. Now, the importance of this meta-analysis is that it included girls and women in the spectrum that we are more interested in, immediately after menarche and the early reproductive years. All right, I've told you about biochemical in vivo outcomes. What about the clinical outcomes? Is there a measurable clinical change that I can tell you, yes, I have started seeing a clinical improvement in these women? There is evidence in multiple studies about the improved regularity in menstrual cycle and improved ovulation rate. Now, this is an endocrine conference. I'm a gynecologist. Obviously, the first thing that I'm going to say is, wait, my menstrual cycles are okay. The ovulation is fine. I'm really happy. But is that all PCOS has to it? Regular menstrual cycles? Obviously not. So let me get to what it can do more, and things get better from here. There is improvement in the hyperandrogenism outcomes, which has been objectively measured by some studies by the standardized acne score. And also endocrine and metabolic parameters of insulin resistance have also improved, which I already mentioned to you in terms of the improved biochemical parameter outcomes. So there are multiple studies to support these support the use of inositols for these uses in metabolic outcomes. So specific to PCOS in reproductive outcomes, there is significant evidence for follicular maturation, luteal phase progesterone, and rescuing the ovarian response to endogenous gonadotropins, the reduction of hyperandrogenemia, re-establishing menstrual cyclicity and ovulation, and therefore increasing the chance of a spontaneous pregnancy. And to me, I'm a happy gynecologist. I have better fertility outcomes. So when we look at the review of studies about improvement in fertility outcomes, the quality of evidence is not as robust. I think this is something, before we label it as the go-to drug for improving reproductive outcomes, we definitely need more evidence, but there are some pointers that it does improve reproductive outcomes. Now, what about gestational diabetes? Is this going, now I have let us say an adolescent with PCOS, and I start her on inositols. I'm going to, with the intent of improving the metabolic consequences for her. She is going to become my next reproductive woman when she plans her pregnancy. Is this going to reduce lower the incidence of gestational diabetes mellitus? There are studies which tell us that there is some use for inositols in primary prevention, in the reduction of gestational diabetes in at-risk individuals who subsequently plan a pregnancy. And inositols, when started early in pregnancy, also have an effect on the subsequent development of GDM during the later course of pregnancy. Okay, all this is fine. I've been talking about girls and adolescents. I've been talking about what is the possible, when these girls grow up to plan a family, what happens to the reproductive outcomes, then when they become pregnant, what happens to their metabolic outcomes during pregnancy. Yes, there is a favorable impact on gestational diabetes. When on inositols, what happens in general to their metabolic outcomes? Yes, there is a favorable impact on their insulin profile, on their metabolic profile. But what about long-term cardiovascular consequences? What about the impact on malignancies in the future? But wait, I'm here to give hope for inositols and pregnancies. I did not promise God with inositols, but inositols is relatively new to us now, probably a decade or so. To comment on chronic illnesses, on long-term metabolic consequences and cardiovascular consequences, we definitely need more time, and I'm sure time will tell. So thank you. I think there is definitely hope for inositols in PCOS, And I probably had a bullet-proof vest on even before the debate started, because I think there is overwhelming evidence evolving which tells us that inositol definitely is here to stay and play a significant role in our management. Thank you.
Thank you, Dr. Swaramya. Thank you for that excellent discussion. So next, we'll go on to So next we'll move on to Dr. Chitra Selvan, who is going to talk about my Inositols and PCOS being just a hype being promoted. So Dr. Chitra Selvan is a renowned endocrinologist who has done her endocrinology from IPGMER, Kolkata in 2014. And she is currently an associate professor in endocrinology in MS Ramaya Medical College, Bangalore. And she has many publications to her credit in national and international journals. And she also has multiple achievements like A.D. Gandhi Award for Excellence in Endocrinology in 2015 and RSSEI Young Investigator Award in 2017. Over to you, ma'am.
Thank you, Endocrine Society of Tamil Nadu and Pondicherry and Dr. Vijay Bhaskar Reddy for giving me this opportunity. It's extremely happy occasion for me to catch up with all of my friends from Tamil Nadu and Pondicherry. Very happy to see everybody here. Thank you, Dr. Swaramya, for that lead up to which is bringing in hope for PCOS in the context of inositol use. And in COVID times, I've been given the job of destroying that hope and proving to you that it is just hype. But I am going to try and remain pragmatic because I'm aware of the fact that we have numerous gynecologists logged in and probably present the argument as more as a review of scientific evidence which is available as of today, and not just a dogmatic argument to just win a debate. So this is the outline. I think we all agree that PCOS is unique in that we have understood so little about the pathogenesis, and we are just beginning to understand the long-term repercussions of the condition itself. And it is quite normal for us in areas with very little understanding to grapple and find anything that might be reasonable to hang on to. So I don't think the fact that we are enthusiastic, probably over enthusiastic about inositol is misplaced at all. PCOS is a condition which is extremely rampant, and there are very few meaningful things that we can rely upon to improve outcomes. As Dr. Swaramya has highlighted, lifestyle modifications are difficult to implement, even more difficult to follow our own selves. So going back to quickly trace the connection between inositol and metabolism and endocrinology and gynecology, notice that the structure of inositol is very similar to the structure of sugar. Its widespread presence in human beings. It can be synthesized in human bodies. There are numerous isomers of inositol. The most commonly alluded to in scientific literature is myoinositol and D-chiroinositol. But there are many other isomers which exist in nature. It's very widely present in numerous food sources, predominantly noticed in beans, some fruits like orange, also present in grains like bread or wheat. But probably the endocrine or the metabolic interest rises from the fact that inositol is a precursor in phosphatidyl inositol, and myoinositol is a precursor which formulates this particular molecule. And what is phosphatidyl inositol? It is an extremely important secondary messenger in the downward cascade of numerous hormonal signaling. And as you can see in this slide, it is a very important secondary messenger in the cascade of insulin receptor. And that probably is the thread that ties inositol to PCOS. So if you can in some way contribute to increased phosphatidyl inositol levels, maybe the downstream metabolic actions of insulin can be improved upon, even in the presence of insulin resistance, which is common in PCOS. That seems to be a very simplistic view of trying to find a solution for an extremely complex condition for which we've not even understood the pathogenesis completely. Not only is it a secondary messenger for insulin and downstream pathway, it's also an important secondary messenger for lipid synthesis of relevance in this conversation, oocyte maturation, oogenesis, and cell morphogenesis. So let's talk about, so does that mean we can take inositol and use it in PCOS? Has anybody even found variations in inositol in women with PCOS? So inositol is excreted in the kidney when it is broken down. So there have been some preliminary reports to suggest that urinary clearance of D-chiro-inositol, which is an isomer of inositol, has known to be greater in women with PCOS as compared to normal women, alluding to what Dr. Swaramya has told us, that there seems to be inositol deficiency or an increased clearance of inositol in the urine. So does that mean we can give inositol and hope for improvement in reproductive or endocrine and metabolic outcomes? So this is a Cochrane review published in 2017, which has tried to look at specific outcomes of oligoamenorrhea, subfertility, and ovulation with the use of numerous drugs which are available, whatever it is, irrespective of how difficult practicing treatment for PCOS is, we still need to base our practices on evidence. And quickly going back to the trials which have looked at ovulation, notice that the trials date back to 1999 and 2003. Draw your eyes to the number of people involved in the trials, 22 in each arm, which has showed the maximum use, 6 of them showing evidence of ovulation than not. And so if we go on to conclude that there is no conclusive evidence to recommend the use of D-chiro-inositol for ovulation. What about endocrine and metabolic parameters? Maybe ovulation is very complicated for us to take a look at and conclude. What about endocrine and metabolic? This is the same meta-analysis which was shown by Dr. Swaramya. I'm just going to go a little bit into the nuances of from where she's drawing that evidence. These are all the 9 trials which are included in the RCT. Draw your eyes to the number of individuals included. They have even managed to publish studies in which there are 10 people in each arm. And notice the follow-up, not one study has follow-up longer than 24 weeks, okay? And take a look at how wide the varying effects of inositol or any form of inositol on fasting insulin is. Note the changes in testosterone. Notice how there are some studies which are on the other side of the midline, and also the change in androstenedione. And with this, they go on to conclude that there is a slight trend towards reduction of testosterone. So when you're not pausing to look into the study and the strength of the study, it's very easy to read the abstract and conclude that, oh yes, my inositol is showing so many changes. I do not know why the endocrinologists are trying to get in my way. But recall the slide which showed you the number of patients included in the study. Gynecologists may come out at me saying, you will never understand the angst that I go through when I'm sitting with somebody who's struggling with infertility. It's easy for you to talk about metabolic outcomes, but I'm the one who's handling IVF and artificial reproductive techniques. So my troubles are unique. So has this been studied and reviewed? Yes, this is another meta-analysis which has looked at inositol in the specific context of fertility, and this is what they found. With the use of inositol, there is reduced FSH dose required, lesser days of stimulation, lesser number of cancelled cycles, but no difference in clinical pregnancy rate. Very similar to the addition of metformin to improve fertility outcomes in PCOS. That's sad news, but that does not justify our use of inositol to every woman who's walking in to our clinic. Just a small twist in the tail. This is a study which looked at D-chiro-inositol at varying strengths, ranging from 300 to 2,400 milligrams daily. And what they found was disturbing, that in the groups which received a higher dose of D-chiro-inositol, there was actually a lower number of mature oocytes. This is what is referred to as DCI paradox, that is D-chiro-inositol paradox. So when you go on increasing the dose of D-chiro-inositol, it actually seems to have detrimental outcomes. All of this seems to highlight the fact that there is no clear evidence. There's also some evidence to suggest that it could actually be detrimental. So what are we actually missing? And this is how I have destroyed hope right up to this point. But now I am trying to probably present data which is building up towards inositol and the level of evidence that is actually available. So there is an enzyme called as epimerase, which converts inositol to D-chiro-inositol. And the trick happens to be in this particular enzyme and the varying ratio between myo-inositol and D-chiro-inositol. So this is a study which looked at ovarian theca cells between women who had PCOS and women who did not have PCOS. And what they found was this, that there is seen to be an increased epimerase activity in women with PCOS, which translates into a ratio of myo-inositol and chiro-inositol, which is lower in women with PCOS than in women who do not have PCOS. So probably the trick is not about whether you're giving inositol or not, whether you're giving a high dose of D-chiro-inositol or not, probably that there is a specific ratio of myo-inositol and D-chiro-inositol, which you should be probably looking at. This is a mouse model study, which did exactly that, replaced myo-inositol and D-chiro-inositol in 40:1 ratio, and found that there was some improvement in the histological changes of the ovaries in mice. Of course, this is a mice model study, but this is a biological plausibility study. So this is the hypothesis that they have, that probably the ratio is what is crucial. And this is where there is probably like an absolute small glimmer of hope. This is a very recently published paper which took a look at metabolic change due to combined treatment of myo-inositol and D-chiro-inositol, which is a pilot study which took at metabolomics. Now, I am not the person to interpret this for you, but there is a trend to suggest that there might be some improvement with the use of the specific combination. Does this mean we can go about and use this in all people we have? Absolutely not. But does that mean there is some need here to specifically focus on this and study this more? Definitely yes. What do the recommendations say? These are the recommendations published in late 2018. Everybody who has a say in reproductive endocrinology is here. You have ASRM, you have the European Society, and in a quick summary of everything that there is available about inositol, that they conclude that it should be only considered as an experimental therapy in PCOS, with emerging evidence of efficacy highlighting the need for further research, right? So if you're practicing evidence-based medicine, this is probably the only slide that you should take away from this entire debate. And I understand that these are difficult times. I understand PCOS is difficult. I understand we are almost in a desert when it comes to options which are available. Is there a biological plausibility? Probably yes. What about the review of evidence as of today? There is no evidence to suggest that it causes meaningful endocrine or metabolic outcomes, no changes in fertility outcomes. Yes, of course, there's a Breaking Bad connection here. Maybe the ratio is what is altered, but does that mean if you replace D-chiro-inositol, it's all good? Maybe not. Maybe you're causing some harm just by replacing high doses of D-chiro-inositol. And the guidelines and recommendations are absolutely clear that it is an experimental therapy. Just because we're in a desert does not mean we run towards anything which looks like water. We still need to hold on to our senses and wait for something meaningful to emerge. That's my argument. Thank you so much for the audience, and I hand over back to our chairperson.
Thank you, Dr. Chitra. That was an excellent argument, and that was a very spicy debate which has gone on. Thank you very much.